So first question is for Sarah Popple. So if the wrong spacer, there's a few different comments went into the chat about spacers and children with the wrong spacers, and so this is really a question about the role that pharmacy can play. So if the wrong spacer is prescribed by the GP, what can pharmacists do to correct that situation?
Thank you. Yes, I have popped a couple of responses in the chat to this. So it does seem to be quite a common problem that the wrong spacer is being supplied for patients. And certainly we do still see older children who have got the little yellow one with the mask, which is unlikely to actually fit their face properly as they get older. And also the volume of that is not quite big enough. So they should have the blue mouthpiece one or the volumatic ones. So there are other generic ones. So I know quite commonly we're using the aero chambers or the volumatics for patients, but there are quite a lot of other ones on the market now. It's becoming a bit more competitive. But the websites for all of these spacers and Asthma UK also have information about which the correct spacers are. So pharmacies really should be informed about what the correct one is, and they should be able to swap them out. So actually, if you get a prescription into pharmacy for the incorrect one, they should be able to just swap it and give the correct device. And I think that's quite key, because there's absolutely no point patients taking these if we're not enabling them. But and there was also a question in the chat just while we're on spacers about recommending them for over 15-year-olds as well. So obviously you are going to get improved lung deposition for anybody that's going to use an MDI if they use it via spacer. But the standard is the recommendation that all up to 15s are using them. So that is why these guidelines have been put in place for pharmacies to make interventions at that age, in that age group. But yeah, so Asthma UK is a really good resource for spacer devices. And then if you look at the individual companies who make them as well, they usually have a poster. So I'm just looking at the aero chamber one on another screen just now. It tells you what age groups they're appropriate for, which colour to use, etc. So that should just be a case of swapping them out and informing the prescriber that they've got the wrong one.
Fantastic, Sarah. So yeah, and yeah, just reiterating your point about the 15-year-old thing, it's not that you shouldn't use spacers after the age of 15. You're saying that you have to use them up to the age of 15, and you know, recommend continuing beyond that, but definitely up to the age of 15 should be using it if it's PMDI. Great. So this one, sorry, with me 1 second. This is an asthma and lung UK question. So Sarah, there was a lot of discussion in this morning's presentations around stigma in asthma for children and young people. Just the question was, what role can Asthma and Lung UK play in addressing this really kind of challenging area?
Yeah, that's really difficult, and it's certainly something that's come through to me since I've joined the charity, and we're actively looking at this at the moment. So at a kind of a top level, I think the charity can champion communication and campaigning to take away the stigma. I've been really struck talking to lots of patients about how they downplay, particularly children and young people, how they downplay the fact that they've got asthma, the fact that they will hide their inhaler, they will avoid situations where they may sort of be exposed with it. We need to normalise having conditions like this. I've worked in previous charities which similarly have had symptoms that have been, you know, especially children and young people have found very embarrassing, and we just need to sort of really expose and make that a kind of just part of normal life, just part of the diversity of what we live with. So I think the charity has a real role to play with that, and we need to mobilise people with lung conditions generally to say, do you know what, we're not ashamed of living with these conditions. These are and we need to be out there on it. So yeah, I think there's a lot to do, but I think we need to bring everybody together to get that message over. If you add up everybody who's impacted by respiratory conditions and lung disease, that's an awful lot of people. You know, we're talking millions and millions. So we should be able to make a movement to address this.
Thank you, Sarah. Yeah, and your ongoing charity's ongoing leadership in this area is obviously always really appreciated. So, Louise, there's a couple of questions in the chat here, which I think are sort of hangovers from Andy's clinical presentation earlier, but came after he'd finished. So I'm going to try and get through a couple of these as well. If a patient's only symptomatic over the winter months, is it okay to only use preventer treatment then, and then consider stopping if they're symptom free?
Okay, so that's a very good question, and I think Andy also answered a question around kind of thinking about preschoolers, and we see that more in preschool children. I think if most children who have asthma, it's kind of more persistent than that. And so I wouldn't just be kind of stopping and starting treatment. I would be recommending they carry on taking it. Particularly, that's why probably we see the spike. One of the reasons we see the spike in September is because children have stopped their treatment because they're well over the summer, and then they're not, and then they're kind of exposed to viruses when they come back to school. Again, coming back, that's where, you know, an anti-inflammatory reliever inhaler approach works well, that you're then tailoring the treatment to the symptoms. So if they are then getting symptoms, they're taking inhaled steroids at that time, so that you're kind of tailoring it. And it's difficult because we don't have that option in terms of a combination inhaler for younger children. As I say, hopefully the evidence will be coming, and we'll then be able to make kind of more definitive recommendations based on evidence.
Right, thank you. Thanks for that, Louise. So helpful. There was, I suppose, just on that, there was somebody else put a question. I'm just trying to find it again around the GINA guidelines. 6 to 11 years old, use a low dose ICS taken whenever SABA taken. This isn't, rather than being in the MART regime, somebody who's on an ICS with PRN SABA. And so the question was, are we suggesting that if they need a couple of puffs in the middle of the day, that they should also be taking their ICS? Is that basically what the guidance is saying? And if they need to do that 3 times a day, are they taking ICS? And then just the rationale, because as the person who asked the question sort of said, well, my understanding is that steroid is not short acting, takes a while to kick in, so why are we suggesting in the acute setting to use it? So just some clarification on the rationale behind that, I think, would be helpful.
Yes, so yeah, the recommendation essentially is that when you need your blue inhaler, you take a steroid inhaler at the same time, and that's based on data from the ASSIST and the TREXA study. What they did in TREXA is they taped the inhalers together because there's not a combination inhaler. Practically, that's really difficult to do, and I think that the person who asked the question also made the point about, then are you going to take a steroid inhaler into school? And so I think from a practical point of view, it's very difficult to do, and I sometimes use that approach, and when I do, I say if you've needed your Sabutamol inhaler, then you take your inhaled steroid when you get home. But I think without a combination inhaler, it's quite difficult to use that approach. And then the question around the inhaled, and just to say that in the studies that have done that, the exposure to steroid was around 25% compared to children who are on inhaled steroid all the time. So we don't kind of end up seeing that overuse. In terms of the other part of the question, was around why take an inhaled steroid. So an anti-inflammatory reliever, the relief of symptoms is being provided by either the short-acting beta agonist or formoterol, which is a fast-acting, long-acting beta agonist. So that provides the relief, and then the inhaled steroid is providing the kind of the protection in terms of treating the inflammation. So it doesn't provide any immediate relief, but if you're getting symptoms, then you're also treating the underlying inflammation. And we know that both SABA-only treatment and long-acting beta agonist only treatment increase your risks. So by having the inhaled steroids, that then kind of mitigates that.
Yeah, thanks, Louise. And it's exactly the same rationale that sits behind MART and as required anti-inflammatory reliever therapy. So it's the same. It's basically the same principle. Fabulous. Okay, next one is for again for Sarah Sleet. I think also more widely as well. I think it was a question around. So, are you aware of Easy Read asthma action plans? Is that something that Asthma and Lung UK have? I wasn't aware that they did, or is it on? Do they, and is it on the radar? If not, and then I think more that would go to everyone else on the panel as well, if they have any links or something they could help with that. So Sarah, to you first, please.
So I am a bit exposed here because I don't know everything that's currently on our website. However, so I can check that one out. However, I do know because that we have a health inequalities action plan around health advice. And one of the aspects that we have been looking at is Easy Read. This is across a lot of our health advice. And we will, if we haven't already got it, we will be doing it very soon, because we're picking up the most commonly used resources, and obviously the action plans are some of the most commonly used resources, and applying Easy Read to it. So if it's not, so the simple answer is, if it's not there yet, it's going to come very soon.
It's a good answer. Thanks for that, Sarah. Louise, are you aware of any Easy Reads kind of versions of action plans? Any that you've come across?
No, I'm not actually. Again, it's a very good point. I mean, we try and use kind of pictorial plans as much as possible, and that's why also kind of having QR codes that link into videos, so particularly the videos on the Asthma and Lung UK website are really useful as well, so that, you know, for people who can't read, then there is the videos as well. But no, I think it's a really good point, and yeah, I'll look out for them on the Asthma and Lung UK website.
And Sarah, had you in pharmacy, as you in your work in pharmacy and asthma, have you come across it at all? The Easy Read ones?
I haven't. No, I haven't seen any of these. But I agree, it'd definitely be a good idea. Because we make great assumptions about what people can understand.
Yeah.
It's really important that this is accessible to everybody.
Yeah, I think we think about translating much more quickly than we think about the Easy Reads. I know, I know Asthma and Lung UK does have guidance on asthma, what is asthma, in the Easy Read format. I think Beat mentions that as well. I don't know if Jen's not here to ask about the Beat Asthma website. That might be a place to look. But certainly there'll be, yes, so it's a question well posed, whoever had put that, and it does sound like we all agree we need them, and sounds like there is something likely to be coming soon. Okay, this is a bit more of a clinical one. So Louise, if rhinitis symptoms were noted at the time of diagnosis of asthma, would you start treatment for both, or would you try and deal with one then the other? What would be your kind of recommendation to those of us who are working in that kind of clinical phase?
So that's a really good question. And the other thing to highlight is that if you have rhinitis, that will often put your exhaled nitric oxide up really high. So we often see very high phenos. So I think it really depends on the initial symptom presentation, and quite a number of children who are referred to me as query asthma, actually it's all upper airway, and so treatment of their rhinitis is key. And we also know that in children with asthma, if they have rhinitis, that will make their symptoms worse, and I would always treat both. So again, establish diagnosis. If there's asthma and rhinitis, treat both. If actually all the symptoms sound like they're more because of rhinitis and asthma is unlikely, then I would treat the rhinitis.
Right, that's helpful and concise. So this one again. Okay, so this is an Asthma and Lung UK one again. So Sarah, you mentioned concerns about the dangers of empty inhalers. Please could Asthma and Lung UK, it's not a question actually, it's an ask. Please could Asthma and Lung UK add information about how to know if your inhaler is empty to inhaler technique pages? I think that would be quite useful to start disseminating that, or having some resources that we could signpost people to.
That's a good idea. I will take that back.
There you go. Change in progress. Let's okay, so another one for Sarah Sleet. So although I think well, I'll ask it. So will the MART information on asthma and lung UK be updated following the changes and updates in guidelines?
Yes, when the guidelines are confirmed, because obviously they're at consultation at the moment. Yes, that information will be updated on the website.
Great. Okay, that was an easy one. All right, so this is a broader one. So what, this is for everyone, we'll just go, so do you have any views on what behaviour changes in air quality strategy could be most effective in schools? So this is a bit of a broader question. Who wants to start speaking first? Who wants to jump in?
Yeah, shall I jump in, since we're doing some work in schools on this? I may be misinterpreting the question. So behaviour change strategies in air quality. I mean, certainly one of the things that we are championing through our work in school is, first of all, get the awareness up. I don't think there's a lot of awareness and understanding in the school population about actually the impact of poor air quality, and then enabling people to understand what is actually going on in their local area. You know, how poor is the air quality in their area, how you know, how they can change routes to school, etc., to sort of reduce risk and mitigate risk. But the other aspect to it is really about, and this kind of goes back a bit to the stigma side as well, is really enabling young people to take a bit of control and to say, actually, we want to do something about this. We need to do something about this, and to kind of be shown to take a bit of a lead in school. It's often linked to an environmental agenda as well, and that's really helpful because that's viewed very positively by young children, young people and children. So I think there's different dimensions to changing behaviour. There's personal behaviour, but there's also changing the behaviour of others. And the final thing I would say is, often, frankly, when we go to politicians and policymakers and say we've got to get change, taking young children and young people along to those meetings and getting them to say about the impact on their lives and their fears for their kind of future and health has been probably the most impactful thing we can do.
Thank you, Sarah. Louise.
Yeah, so in terms of air quality in schools, good ventilation is really important. Kind of any initiatives to reduce traffic around, particularly around drop-off, cars idling, those sorts of issues, trying to reduce that. And then also planting trees. So if there's any space to plant any trees, that can help protect from particulate matter.
Yeah. Sarah, thoughts?
Yes, so I think most of it's been covered there. My thoughts on it were that schools all have a traffic management plan, don't they? They had advice for children about walking to school and what they could incorporate, what routes they should take to maybe minimise exposure to pollution, but also, as Louisa said, not having cars idling and dropping off. And maybe have walking buses or something to help children not be exposed at the school gates. Everybody seemed to be very aware of ventilation needs and air quality when we had COVID, but now everybody's forgotten about it again. So it maybe just needs to be put back into the school agenda to think about.
Yeah, some good points there all. Right, and then I think just a last quick thing I think was Louise, just coming back to the referrals into the severe asthma service, and just thinking about kind of referral criteria. I wondered to what extent you feel like lower down the system, the speed with which additional need is identified and systems in place to identify additional needs, and even systems to react to those changes, whole system mechanisms to react to those increased need are having an impact on how quickly children are referred in, or whether there are cases that could be dealt with in the community without being referred in. Yeah, no,
I think certainly if we're able to, if we can do all those basics every time a child is seen and control isn't poor, then they might not need onward referral. That's that kind of first piece, saying, has management been optimised? If it's been optimised and the control improves, great. It's if it then hasn't been optimised and then control is still poor. So I think somebody put a comment in saying, if you use those criteria, asthma services would be overwhelmed, and that's absolutely true. I don't think we need to see all. I think actually, the thousands of children I showed in those data. I think there needs to be that optimization first, and then the consideration of referral. It's those kind of two steps, but really we are seeing very, very small numbers compared to the number of children with poor control.
Thank you, Louise. So thank you to our speakers from that last session. Thank you all of you for your contributions and for taking part in the panel as well. That brings